technology, as well as medication access in the setting of closed patient assistance programs, which I know affects all of us. So today we have Dr. Diana Isaacs. She's an endocrine clinical pharmacy specialist and the Director of Education and Training in Diabetes Technology at the Cleveland Clinic. Dr. Isaacs earned her PharmD from Southern Illinois University, Edwardsville, and completed a pharmacy practice residency at the Philadelphia VA. Dr. Isaacs serves in leadership roles for several pharmacy and diabetes organizations. She served on the ADA Professional Practice Committee from 2020 to 2023, the committee that updates the ADA standards of care. She is a national board member of the Association of Diabetes Care and Education Specialists. Dr. Isaacs was awarded the Ohio Pharmacists Association Under 40 Award in 2019 and was the 2020 ADCES Diabetes Care and Education Specialist of the Year. In 2022, she was inducted into the SIUE Hall of Fame for her far-reaching contributions in patient care. We also have today Dr. Brandon Keith. Dr. Keith is a diplomat of the Pharmacy Leadership Academy and is board certified in ambulatory care. He holds a Doctor of Pharmacy degree from the University of Maryland School of Pharmacy and a Bachelor of Science degree from the University of Maryland College Park. After graduating from pharmacy school, Dr. Keith completed a one-year residency training from Johns Hopkins Home Care Group. He then graduated from the ACCP Pharmacy Leadership Academy program. He also holds certification in ambulatory care pharmacy, medication therapy management, and immunization delivery. Dr. Keith has over 7 years of experience in direct patient care of solid organ transplant patient population. He is skilled in pharmacy precepting students and residents, patient counseling, medication reconciliation, polypharmacy, and health and wellness. His goal is to create a personal relationship with each patient to best understand their goals and serve their needs, to make sure his patients have a clear understanding of their condition, as well as their medication purposes, side effects, how to take their medication, and to provide education not only to the patient, but to the caregiver. Lastly, Dr. Keith is passionate about educating, encouraging, leading, and inspiring his patients and others around him, and promoting the value of diversity in healthcare provider and patients. Before we start, here are some statements regarding CE today, which we'll cover again at the end. And without further ado, I'm going to hand it over to both Dr. Isaacs and Dr. Keith for their presentations today.
Great. Well, thank you so much for that introduction. I am Diana Isaacs, and I'm going to get us all started with wearable diabetes technology. And with that, hopefully I can advance these slides. There we go. Okay. So here are my disclosures. And then in terms of what I want to talk about, so I have 25 minutes. So I was trying to cover really the high level, what's the key things. And I determined, I think continuous glucose monitoring is probably, in terms of wearable technology, things that we're more likely to come across. So I am going to focus on those. However, I will talk about the integrations with like the different insulin pumps as well in that. Okay, so kind of all level setting and everything when it comes to continuous glucose monitoring. These are devices that measure glucose levels every 1 to 5 minutes, and then they're recording the levels every 5 to 15 minutes, depending on the specific device. So if you do the math, that's actually 288 readings per day. So it really is providing a lot of information. There are 3 different components. So there is the sensor that you can see in this picture, and that is the part that is just, it's a tiny bit below the skin, sensing the glucose in the interstitial fluid, and then communicating through a transmitter to some type of reader, receiver, or most often it's just someone's smartphone. Depending on the device, the transmitter might just be completely attached to the sensor and it's disposable, or it may be a separate piece that either needs to be saved in between use or even needs to be charged in between uses. So I think this illustrates very well the difference between BGM or blood glucose monitoring and CGM, continuous glucose monitoring. And what you are seeing here is representative of a 24-hour time period, 0 to 24. So like midnight to 12 a.m. And it's really common. One of the things that I do in my role is within our kidney transplant clinic, a lot of patients either had diabetes prior to their transplant, or they developed steroid-induced diabetes from the high doses of steroids. And so many of them are placed on some type of mealtime insulin. And so we're asking them to check their glucose levels 4 times a day. And so we might see information like this. And if this is what I saw, I would say, okay, this looks mostly to be in range between that 70 and 180, which is that goal target range. But when you put CGM on a person, you see everything in between. And in this case in particular, we see that there's actually undetected hyperglycemia, which is really common with the prednisone use, that glucose starts to spike after breakfast and kind of continues on throughout the day. But what's really concerning here is there's also this undetected hypoglycemia overnight. And I'm happy to say that one of the initiatives that we've done now is with our discharge, we're actually putting most people on CGM. They do need to have a compatible smartphone, but it's really been a game changer in terms of being able to see more data, as well as we can connect them to our system that we can review their data remotely as well if we're not able to see them in person. So in addition to having all this data, it's great for the care team. We can look at all the data. For the person living with diabetes, it's also great because they get real-time data. And so they can actually get alerts to high and low glucose values. Many systems even have predictive alerts, so it can predict if it's going to go low in the near future. And this really, it's a game changer because even though we'll ask people to check their glucose, like before they're going to drive a car, before they're going to exercise, the reality is someone could check their glucose and it could be 110 and they say, okay, it's fine, it's safe to do this. But if it was really 110 with these arrows going down and dropping, then it really wouldn't actually be so safe to do that. Now, there's two main categories of CGM. There's professional and personal. Professional is owned by the clinic and essentially lent out to the person with diabetes on a short-term basis. So a minimum of 3 days for the purpose of billing, but depending on the device, it can be up to 14 days. And there's not like integration with professional CGM and things like connected pens or insulin pumps. But the real advantage of this is the coverage is outstanding. Most people have coverage for this at least a couple times a year, even those that are not taking diabetes medications, and even pre-diabetes will sometimes have coverage. And so it's just in terms of access, wider access for those that can't afford or don't want to continually use personal CGM. Now, personal CGM is what's owned by the person with diabetes and really meant for long-term use. And while actually insurance coverage might have initially kind of been focused on type 1 diabetes or those on intensive insulin regimens, we're now seeing that insurance coverage has widely expanded. And in fact, within the Medicare population, last April, they actually expanded it now to include any person on any type of insulin. So that means even those just on a long-acting insulin, not on mealtime insulin, now do have coverage with Medicare. And in fact, there's even a second component to that. Even if a person doesn't have insulin, if they have what's called problematic hypoglycemia, where glucose levels go to the level 2 below 54, at least twice with some type of intervention, then they also could qualify for CGM. And we see a lot of private payers also follow this. We're very fortunate in Ohio, our Medicaid plans actually cover personal CGM for all people with diabetes. So that's been really great to be able to access that as well. So when it comes to the professional CGMs, there are two. There's the Libre Pro and the Dexcom G6 Pro. Big differences are that the Dexcom is good for 10 days, Libre is good for 14 days. But the other big difference is that the G6 Pro comes as a blinded or unblinded. What blinded means is that you don't see the readings while you're wearing it. The person with diabetes doesn't see it. That's often used like for research purposes. In the case of Libre Pro, it's only available as a blinded. But G6 has the option to also use it as unblinded, where a person can see their readings while they're wearing it. The key is that they do need to have some type of compatible smartphone or device to be able to see those readings while they're wearing it. So let's talk more about the personal CGM options, because I think that's what we're much more likely to encounter. And there are 4 key brands. There's the Libre, There is the Eversense brand, which is the only implantable CGM. There's the Medtronic Guardian, and then there's Dexcom, now G6 and G7. And there's two classifications. There's intermittently scanned or flash CGM, where you scan the sensor with some type of compatible, either a reader or with a smartphone. And then all of the other types of devices are what we call real time, that you don't have to do some type of specific intervention to see the readings. And really only the Libre 2 is an intermittently scanned. Everything else here is considered a real-time CGM. So let's talk a little bit about the different types of systems. I'm going to start off with the Dexcom, and I included some pictures here. This is a one press inserter, but there is this separate gray transmitter that does need to be attached and saved in between use. So when ordering this, you need to make sure you're also ordering a transmitter and sensors. The sensors are good for 10 days, so you need 3 sensors per month and then 1 transmitter every 3 months. There is a receiver option that you can use with this. Many people just use their smartphones. And then this does have a high, low, and predictive low alert. So if it's predicted to hit 55 in the next 20 minutes, that alert can go off. And then in terms of compatible apps, there's the Dexcom G6 to see the readings. To share the readings with the clinic, there's the Dexcom Clarity. And then this can be shared with up to 10 followers via the Dexcom Follow app. Now, Dexcom G7 is essentially the newer version of the Dexcom. And there's definitely some enhancements here. One is the fact that although it is still technically considered a 10-day wear, there's this 12-hour buffer room. So it's nice because if you don't want to change it at exactly the same time 10 days later, now you can change it later in the day if you want to. But the other nice thing is the warm-up time has been shortened from 2 hours to now 30 minutes. So warm-up time is when you first put the sensor on, you don't see readings right away. You have to wait until it's done warming up. So the fact that this is shortened is really nice. And in fact, you could even put a new one on while you're still wearing an old one, and that warm-up will automatically start, which means that there would be no gap in having readings, which is nice because 2 hours can feel like a long time for someone that's used to having constant access to what their blood sugar is. Both the G6 and the G7 don't have finger stick calibrations that are required. And what that is just doing a finger stick to ensure the accuracy of the device, make sure it's not veering off too high or too low. There are optional calibrations, though, that are available. And then perhaps probably the greatest improvement with this is just that now the transmitter is fully disposable, more like what we're used to with Libre systems. And so it just makes it easier because I've had a number of patients accidentally throw away their transmitter over time or it falls off. And so it's just one less piece to worry about. Also, one less piece to prescribe. And then also in terms of starting it, there are codes for this one. There's a sensor code. And then with the G6, there's actually a transmitter code. So now there's not a transmitter code for the G7. It's just this 4-digit sensor code. There's also a QR that you can scan with the phone as well. There's a little bit more customization with alerts. There's things like rise alerts and fall rates. And while the G6 has those too, these are more customizable in terms of you can do things like, well, maybe you want to know when it's rising quickly over 200, but you don't want to know if it's rising quickly in your 70. So you can customize those a little bit more. And then for the apps, mostly they're the same. You've got the Dexcom Follow and the Dexcom Clarity, but one of the differences is it is a Dexcom G7 app instead of the G6. And they did add a few features to the G7 app, like now you can see some time in range statistics and the average glucose and the estimated A1C, versus with the G6 app, really all you can see is the last 24 hours of glucose data. Now, when it comes to Medtronic, the Guardian systems, this is confusing because there's 3 listed here. There's a Guardian Connect, a G3, and a G4. And essentially, why are there 3 different ones? They all actually look the same. That picture you see up at the top, they all look like that. But the difference is really, one is considered a standalone system, the Guardian Connect, that works with a compatible smartphone. And then the G3 and the G4 are the ones that work with the insulin pumps, namely either the 670G or now the 770G, and then earlier approved this year was the 780G. Hopefully, most people are going to be switching to the G4 because what's improved with the G4 is they finally got rid of the calibrations. In the past, this required at least 2 a day. When used with the insulin pump, it required like 4 to 6 a day to optimize the system. And now with the G4, they've gotten rid of that. But one of the kind of annoying things is if you look at all these pictures on here, that inserter in the middle, that is what's used to insert the sensor. So you have to carry that around in case it falls off or something. And then there is a transmitter that is used for at least a year, and it needs to be charged every 7 days in between changes. So just a little bit of kind of extra things. But with the Guardian Connect system, one of the neat things is that there are more predictive alert options, like 60-minute predictive alerts for highs or lows, which is really the most customizable out of all of the systems. And then Freestyle Libre. So I think this is probably one that we're most familiar with. And I think with the affordability, it's led to widespread use because this one has a manufacturer coupon with commercial insurance, which often makes it not more than $75 per month. And then both Libre and Dexcom devices are available through Medicare. So I would say those are kind of what we often are seeing. Plus, they're both pretty easy to use. So this is a 14-day wear. Soon there is going to be an upgraded 15-day sensor, but right now it's still 14 days with a 1-hour warm-up. And this is considered to be that flash CGM or intermittently scanned. So you would scan it. And an important counseling point for patients is to try to scan it at least every 8 hours. Otherwise, there's going to lead to some of those data gaps. It is a nice one-press inserter, and this is compatible with the Libre 2 mobile app. And then there's the Libre Link Up, which allows up to 20 followers. Libre View, which is embedded in the Libre 2 mobile app, is what allows people to be able to share their data with the clinic. And then Libre 3 has had several enhancements. Probably the biggest one is the fact that it's considered a fully real-time CGM. And so people don't have to scan it to be able to see the readings. And as healthcare team members, we don't need to rely on a person scanning it. So it's been great because now we have full access to the data, regardless if a person scans it or not. As long as they're wearing the sensor, we will see the data. There is a 1-hour warm-up. You do actually need to scan it to first start the sensor, so that is an important point. Initially, when this came out, there was not a reader, and for that reason, people with Medicare could not get this. They had to stick with the Libre 2. Now the reader is available by DME. It is not yet available in pharmacies, so people can't get it from the pharmacy, but they can get it through DME, and that does allow people with Medicare to get it. And so we've actually, with our discharge program, we were using Libre 2 and we've switched to Libre 3 because now people with Medicare are able to get that. In terms of the mobile apps, very similar, except it's a Libre 3 mobile app. There's still the Libre Link Up for sharing, and Libre View is still embedded in there. And it is a smaller size. They say the size of 2 stacked pennies compared to the Libre 2, which is the size of 2 stacked quarters. Also, the insertion's a little bit easier. So with the Libre 2, you have to load it. You unscrew it and you load it into another device to get the needle in there. This one, the needle is already in there, but you still do have to unscrew it. And I do find there are some people with more limited dexterity, and sometimes that can be an issue. And then the last category is our Eversense, and this is the implantable CGM. Now, the sensor is what's implanted into the upper arm for 180 days, so it needs to be changed twice per year. There is an outer transmitter, and that transmitter needs to be worn to be able to get glucose readings. And then it works with a compatible smartphone. That transmitter does need to be charged every day, so that's an important component. And there are calibrations required with this device. 2 per day in the first 3 weeks, and then 1 per day every day after that. And then there are, in terms of the mobile apps, there's the Eversense CGM Mobile. There's also the Eversense Now, which will allow up to 5 followers. And there are on-body vibration alerts with the transmitter. So even if someone doesn't have their phone nearby, they can still get alerts for highs and lows. And one of the pros of this device is the fact that with all the other sensors, let's say someone wants to take it off because their skin is itchy, they just don't want to wear something, I don't know, they're going somewhere, they don't want people to know they have diabetes. It's not so simple to just take off a sensor. I mean, it is simple, you just pull it off. But the problem is you need another sensor. You can't just reuse it. You need a whole other sensor to put it back on. And those can be expensive. And so the reality is people can't just choose to take them off early. With this, someone could remove it at any time. Also, for someone that needed maybe frequent MRIs or CT scans, which you have to remove sensors for, this is kind of nice because you can easily take that transmitter on and off and not have to worry about that. So in terms of all of these different devices, here's a table that really compares them. And just some things I want to point out that I haven't mentioned so far is the integration. So the Dexcom G6 is currently what's integrated with several devices, the t:slim X2 insulin pump, the Omnipod 5 insulin pump, as well as the Beta Bionics iLet. And with that integration with all of those pumps, it actually automates insulin delivery. It also has compatibility with the InPen as well as there's the Tempo Smart button that goes on Lilly pens for keeping track of insulin doses. And so it has that compatibility with all of those things. The Dexcom G7, we expect it to have that compatibility very soon, especially with the t:slim X2. I don't know how soon the iLet and Omnipod 5, but eventually that is where things are heading. There already is actually compatibility with the Tempo button, as well as InPen. It'll work with InPen as well. Now, Libre 2, we're also expecting in the near future to have this compatibility with t:slim X2. It has been cleared for use. It will be the upgraded sensor, the one that's 15 days, but we do expect that to happen. And likely we'll see it with other systems in the near future as well. Currently, it does work with one system called Bigfoot Unity. These are smart pen caps that actually go on insulin pens. Now, it's very interesting because right now they're kind of in this transition period where they were only sold through these remote monitoring programs and they're switching to pharmacy. However, Abbott just bought Bigfoot Unity. So it'll be really interesting to see kind of what the future holds. But overall, I think that's a positive thing because we will see further innovation in this space. Libre 3 does not have the integration. We do expect in the future it will. And then, of course, the Guardian sensor will integrate with the Medtronic pumps as well as InPen because InPen is owned by Medtronic. And then Eversense does not have any integration at this time. You will notice there's some differences in the water depth. They're all considered waterproof. People always ask me, can I shower? Can I bathe? Yes, please do. But there's different depths in terms of how long you can stay underwater with these systems. And I do advise people to just be careful in terms of not scrubbing, not lathering too much soap directly on top of these devices because otherwise they could end up coming off early. There's also differences with the FDA approved sites. You'll see many are the upper arm. For Dexcom G6, it's actually the abdomen. For the Guardian 3 and the Guardian Connect, it's the upper arm or the abdomen. For the Guardian 4, they only got the approval for the upper arm. And then for Libre and Eversense, it's only the upper arm. That being said, we can use clinical judgment to advise other spots. Just like insulin can be injected in multiple places in the body, these sensors, they get approved for use because that's where they're studied. And it is thought definitely the arm is one of the most accurate places, but sometimes the arm just doesn't work well for some people. And so we can always use our judgment to say, maybe for one person, the abdomen is just going to work a little better, maybe the upper leg. And so we can individualize this and just letting them know that this would be considered an off-label spot. Other super interesting thing is that this year, pregnancy clearance. So actually, the G7 and Libre 2 and Libre 3 have been cleared for use in pregnancy. And I actually do a lot of management in pregnancy. And so this has been a big game changer. And we are starting to use it. We're starting to get better coverage in this population. And so that's been very, very exciting. And then, of course, with us all being pharmacists, understanding the drug interactions. So hydroxyurea, we do see that with the G6, G7, and with the Medtronic Guardian systems. Vitamin C does interact with the Libre systems, doses over 500 milligrams per day. It is dose dependent, so even higher doses will have more of an interaction. And it's a very important counseling point for patients, but with their upgraded sensor, which will come in the near future, that will be mitigated. So we'll only have to worry about that for a little longer. And the reason is FDA, before they were going to integrate with insulin pumps, they were very concerned about this vitamin C interaction because so many people take vitamin C. And then acetaminophen does interact with the Guardian system at higher doses. It used to interact with Dexcom systems. It doesn't anymore, except at doses over 4 grams per day. So it's still possible if someone was taking more than the max dose, but at the usual doses, we don't expect that. And then Eversense actually has interactions with the tetracycline antibiotics as well as mannitol. Integrated CGM. So to have this classification, it means that you have to meet even higher accuracy standards than the minimum to get approved. You will notice I did not even put accuracy. We have a term to describe accuracy called MARD, mean absolute relative difference. I didn't put that on there because there's too much controversy over it. There's a million ways you can assess MARD. But the bottom line is that if you have this iCGM status, you must meet higher accuracy standards to integrate with compatible insulin pumps. And the Libre 2, Libre 3, Dexcom G6, and Dexcom G7 all have met that. So these are the various smart insulin pumps that are available. And you will, the currently Omnipod 5, Tandem Control IQ, the Medtronic systems, and the Beta Bionics iLet. We have 4 automated insulin delivery systems that a person can choose from. And at this current moment, as of today, it's Dexcom G6 that works with 3 of these. And then the Medtronic, the Guardian sensor that works with the 670, 770, 780G systems. And then we've got others coming in the pipeline. Mobi is a new algorithm with Control IQ. Tidepool Loop is a mobile app that will work with compatible pumps and CGM, and then this other one is AccuCheck Solo. So stay tuned for all of that. And then I just wanted to point out, I know this is a lot and it's so much to keep up with. Fortunately, there's some great resources. Diabetes Wise and Diabetes Wise Pro are non-industry sponsored websites where you can learn about the different diabetes wearable technologies and really get an objective viewpoint. The diabeteswise.org is the patient-facing one, and then Diabetes Wise Pro is for the healthcare professional. And then sharing data. So sharing data, these are the associated mobile apps that I mentioned, many of these when I was talking about the CGMs, and then the available data sources. For example, if you're using insulin pumps, that those can also integrate with those. 2 of them I just want to call out. The Tidepool and Gluco are what we consider device agnostic. They don't work with a specific system. They actually can work with multiple systems versus all of the others are owned by the respective company. And so they pretty much just work with the company's products. So in summary, there are 4 CGM brands. And CGM has really gotten a lot easier to use. It is definitely more affordable. It's more accessible. There's better coverage than ever. It's getting smaller, more disposable, either no calibrations or less calibrations and better integration. It can be integrated into a variety of insulin pumps, connected pens, and mobile apps. And I thank you so much for listening. I know we're going to have time for questions after you hear from Brandon. Here's my contact information. I also do have a podcast if you want to learn more about diabetes technology. And with that, I will turn it over to Brandon. Thank you so much.
All right, good morning, everyone. I'm here to talk to you all about medication access in the setting of closed patient assistance programs. So we have 2 learning objectives for today. The first is we need to set the groundwork, understanding the types of medication insurance coverage and how they differ. And then we'll get into what I think is the main learning objective, which is to explain additional assistance options when medications are unaffordable. And unaffordable is different for every patient. So a little bit on the insurance coverage overview. So most transplant centers are going to do a financial clearance of some sort. The details of that are going to differ with each transplant center, as we know. On the pharmacy side, it is often wondered what is the clearance that is given. Many times there is verification if a patient has an active prescription insurance plan. However, there is not always a deep dive or research into what the patient's anticipated medication copays will be following transplantations. So we know that costs are going to vary depending on each patient's specific prescription insurance plan and medication. And so every insurance plan typically has what we're likely all familiar with, which is a formulary, a list of prescription drugs covered by the drug plan or another insurance plan offering prescription drug benefits. So on this formulary, you typically have different tiers. You have tier 1, tier 2, tier 3, and tier 4, for example. Tier 1 are usually the drugs that they want you to use before tier 2, tier 3, tier 4. So they have the lower copays. That is usually those medications that are generic. They're usually cheaper. And then as we move up the tiers, usually the expense of the medication as well as the cost that the patient sees typically goes up. So you'll see, for example, tier 1 metformin, it's been around a long time. It has the lowest copay. Then as we move up into tier 2 with empagliflozin, sitagliptin, tier 3 insulins, we're starting getting into more pricey drugs. And then tier 4, the newer drugs like semaglutide. So let's break down the types of insurance. And this can be very important as we think about patient assistance programs, because the type of insurance that a patient has is going to determine or help to determine partly what type of patient assistance program they will be eligible for. And I'll go into more detail later, but just want to provide the foundation for the types of insurance. So typically for my pharmacy at the Johns Hopkins Hospital, we will ask, or we will do a benefits investigation to determine what kind of insurance the patient has. Do they have private insurance, commercial insurance, which is usually through their employer, or do they have a governmental type plan? And so the government funded governmental type plans would be Medicare plans and Medicaid plans. And so Medicare would include Part B, which we usually see is paying towards usually our immunosuppressant medications. Medicare Part D, those could be your Advantage plan, other types of insurance plans that are covering the other medications. And then we have the Medicaid plan, which is going to be specific to each state. So commercial insurance or private insurance. So usually employer funded, usually through your work, issued by the following organizations, usually Caremark, Aetna, Blue Cross Blue Shield. When you hear this in clinic, when you see this in the system, you pretty much know that it's going to be private insurance. And this insurance is usually less restrictive. It usually has more coverage of medications. And typically for patient assistance programs, it's usually a little easier because there's things that we can use for commercially insured patients that we are not allowed by law to use with government plans. So this is just an example of a commercial insurance plan, just so you would be able to recognize it if you were in clinic or you were in a patient's room, they were to show you their pharmacy plan. You're typically looking for information like a BIN, a PCN, a group number, ID, and that would be the billing information that typically the outpatient pharmacy would need in order to bill the medications. So switching gears to what is Medicare, and I'll kind of breeze through some of this, thinking a lot of us are familiar, but Medicare is a federal government program that provides healthcare coverage for individuals that are 65 or older or have a disability. End-stage renal disease is a covered diagnosis code for patients to be able to use Medicare Part B to pay towards their immunosuppressant medications. And we'll talk about how much coverage they get. So with Part B, it's typically going to cover, as we mentioned, or as I mentioned, transplant medications, office visits, vaccinations, medical equipment, and it does cover 80% of the cost of the medications, meaning that there will be a leftover 20% copayment for the patient to pay. So we have Part B under Medicare, and then we also have Part D. And Part D would be able to cover all the rest of the medications if they had a Part B plan. So again, for Medicare Part B, it's used to cover anti-rejection medication for kidney transplant recipients for only 36 months or 3 years. And I think a lot of us are very familiar with this rule. Many of us have asked what happens after those 3 years. Oftentimes our patients can run into issues in being able to afford their medications when they lose that 80% coverage that Medicare Part B was paying towards their immunosuppressants. And so just wanted to briefly mention, as many of us are aware, the passing of the Immuno bill. And so for, in my professional opinion, a small subset of patients, it can be advantageous for them to sign up for this extension of immunosuppressive drug coverage. So this is just an example of what a traditional or old school Medicare Part B plan looks like, or the insurance card. And so just wanted to break down deductible coinsurance. So, we usually show this slide to patients when they're in clinic just to talk about Medicare Part B. How much is Medicare covering? How much are they covering? So again, 80%, 20%. And so, for example, Shelly, she's getting ready to be discharged from a hospital stay after a kidney transplant. She's got Medicare Part B, which will cover 80% of the cost of her immunosuppressant. So if, let's say, total cost of her CellCept or mycophenolate mofetil is $120, how much would her copay be? So we do the math and we see that her copay would be the $24, because that is 20% of $120. So looking at Part D, Medicare Part D is generally for patients who are over the age of 65, but it can also apply to patients who have disabilities or low income. This is a voluntary plan. Patients are not required to sign up for Medicare Part D. It's designed specifically to cover those medications that Medicare Part B would not cover. So we usually think about the immunosuppressant group as the main medications that Medicare Part B would cover. Medicare B would also cover things like nebulizer solutions with an appropriate diagnosis code. Medicare Part B could also cover blood glucose testing supplies as well. And the interesting thing, or the important thing to note, is that Medicare Part D does have a unique thing called the coverage gap or the donut hole. And oftentimes this is when patients can reach a point where there's a coverage limit, where the amount that they have paid, the amount that the insurance is paid, is reached a certain limit. And so now they are being charged even higher copays than those tiers that I had mentioned before. And this is really when patients can get into a situation where the medications are unaffordable. Oftentimes, the percentage of the drug that they're paying is at a higher rate. It might be at like 25%, where it was at a much lower rate before. So Medicaid. So patients with Medicaid, typically these patients are going to be able to have their medications at a very low or no cost to them. Typically patients with Medicaid would have copays of $1 or $3 or no dollars. This is a state-operated medical assistance plan available to those who have lower income or people with disabilities. The one thing about a Medicaid plan is that the drug coverage can be very restrictive. Oftentimes with Medicaid plans, we can get into situations of prior authorizations or approvals needed from the insurance company, which can restrict or make it difficult to be able to get patients medications in a timely manner in which they need it. And sometimes we have to go through patient assistance programs. So this is just an old school example of a Medicaid card example. So let's move into assistance. So when we think about medication assistance, and this is totally outside of your transplant center, totally outside of your social work department. So what are the patient assistance programs that exist? We like to break them down into two different boxes. So we have the insurance assistance programs, and then we have the manufacturer assistance programs. So just a little bit more on that. So let me go back a slide. So insurance assistance programs and manufacturer assistance programs. So I think about copay cards. A lot of times we think about, does a medication have a copay card? And then we think about, does a medication have a free drug program? So that's how I split them. So with a copay card, that really is when the insurance company is paying towards a medication, and then we're trying to lower the cost and we apply a copay card. When we think about the manufacturer assistance programs, that's coming directly from the drug company, and we are hoping to apply to see if the patient can get the medication for free. And usually the medication is shipped directly from the manufacturer assistance program. And there are going to be different patient assistance programs qualifications that will determine whether or not a patient is eligible for a copay card, an insurance assistance program, or a manufacturer assistance program. So what is patient assistance program, or PAP as we call it at my institution? It's extra financial help provided by drug manufacturer companies. It's utilized to assist patients in lowering their medication costs for either our patients that are uninsured or underinsured. And I always like these terms because many people can have active prescription insurance coverage, but we consider them to be underinsured because they're not comfortable, they're not able to afford their medication copays on a consistent basis. And so next, depending on your patient's household income, we can look at whether or not they are eligible for patient assistance programs. So we usually look at a couple different things. We look at insurance status, and then we also look at financial income to help us determine whether or not you would be eligible for free drug. And so we could go the patient assistance programs route with the free drug, or we could also go through a potential copay card, or if there's a grant available, we could also apply for that. So this is an arrow of the direction of where I think everybody should go if you are looking for a process a sequential stepwise process of how to get patient assistance. So the first thing you want to ask yourself is what type of prescription insurance does a patient have? Do they have a commercial plan, or do they have some sort of governmental plan? That's going to determine whether or not they are eligible for a copay card, whether or not they are eligible for potential free drug from a manufacturer company. So we ask what type of insurance does the patient have. Then we look at, is the patient's household income, let's say if we're going for free drug, is it within the requirements? And then another important question we want to ask is, has the insurance already approved the brand name version of the medication? So the large majority of assistance is not available for generic medications. So you always want to figure out what is the cost of the medication and what is the medication. Is it for the generic or is it for the brand? A lot of patients can have expensive copays for the generic. However, there's no drug company that is going to have a copay card for the generic medication. And there won't be usually a free drug program for the generic medication. So we have to ask ourselves, is the coverage for the brand name product? And if not, we need to see what would the cost of the medication be for the brand name of the medication. And then from that point, can we then start to seek assistance? So sometimes that might require pursuing a prior authorization in order to get coverage, or at least try through that process before we can pursue patient assistance programs. So I put together this table and I wanted to share some of the what we call the repeat offenders, or the medications that we get the highest requests for PAP or patient assistance programs. These are the medications that tend to have the highest copays. Patients struggle with, the leftover costs that they have to pay. And so we put together this table, and we actually have this table or a similar table at the bottom of pharmacy test claims. So for all of our solid organ transplant patients at the Johns Hopkins Hospital, we will run pharmacy test claims proactively, either before transplant or usually on post-op day 0 or 1. And we'll have the list of all the anticipated projected medication copays for the most commonly prescribed anti-rejection, anti-infection, transplant-associated medications. And then at the bottom of all of those copays, we will have the information for the providers, for the social workers, for the pharmacists, to be able to see what would be the requirements for pursuing patient assistance programs. And so you'll see some of the most commonly high copay medications: Valsite, Invarsis, our insulins, and Eliquis. And then you will see in each column followed after the PAP medications, you will see the type of insurance, So again, we want to see what type of insurance they have or if they're uninsured, and whether or not we need proof of household income, which can often sometimes be challenging. Many patients who have been admitted to the hospital or coming in clinic, a lot of them don't have household income ready. They may not have it readily available at home for a caregiver to grab, but oftentimes this is information that we are going to need in order to pursue patient assistance programs. So just looking, for example, at ValSite. So many of our patients might have a Medicare Part D plan or a commercial insurance plan. For a long time, we were able to pursue and get approval for patient assistance programs. And most recently, over the last several years, we have noticed that a lot of the patient assistance programs have been closing or they have been getting more restrictive. So what do you do? And we're going to talk through some of those scenarios. So just to highlight ValSite, we see that we were notified at the beginning of this year that there is no more assistance available for new patients. So we were no longer able to refer patients for the free drug program. Fortunately, they were kind enough to extend the program throughout the end of this calendar year for our patients that had already been enrolled prior to the end date. The other thing for our commercially insured patients, we were able to get copay cards. They also stopped the copay cards. So we were left in a situation, or we now are left, where we don't have any assistance through the drug company for ValSite. And so what do we do? And just to share another example we see with Envarsus, we realized at one point the drug companies were starting to deny our patient assistance programs applications for our liver patients, our lungs, our hearts, where we were trying to put them on Envarsus. We could not get assistance. And I think their argument was because the approval was for kidney transplant recipients, they were aligning their patient assistance programs for those patients. And so unfortunately, we were not able to get anyone but a kidney transplant patient approved for assistance. But fortunately for our commercially insured patients, even those that were non-kidney transplant recipients, we were able to get them copay cards. So that is still an option for those patients who have commercial insurance. So I wanted to walk through just two examples of patient assistance programs that has happened at our hospital. I wanted to show an example of an open PAP example. So for example, let's say you are the pharmacist, you're meeting with patient LT, you're meeting to discuss the purposes, side effects, administration, and the copays. Let's say insulin is newly needed, given the patient's medications have raised their blood glucose. You've got a 30-day Novolog copay that is $324. It's not affordable to the patient. So you want to ask yourself those three prime questions. What type of prescription insurance does the patient have? Is the patient's household income within PAP requirements? Has the insurance already approved the brand name version of the medication? So our answers, fortunately for us, the patient has a commercial employer plan. Let's say they have Aetna, and it does pay towards the Novolog. It just leaves a hefty copay of $324. So in this case, because the patient has commercial insurance, we don't necessarily need to go find out what their household income is, verify that. We can just use a copay card. And that copay card would allow us to bill the insurance and then split bill and then bring the cost of the medication down. Oh, and then this is just a potential opportunity to lower the cost, and we can use that $15 Novolog copay card. So let's go into a closed PAP example. So we're meeting with patient KT. We're having the same conversation. Valganciclovir is going to be needed for 6 months. We find out that there's a 30-day valganciclovir copay that is $688. I do want to note this is for the generic valganciclovir. And so we want to ask those three prime questions. What type of prescription insurance does the patient have? Is the patient's household income within PAP requirements? And has the insurance already approved the brand name version of the medication? So In this instance, because the program has ended, we really wouldn't need to go through all of this. We already know that there's not going to be assistance available. We don't have a copay card. We don't have opportunity to potentially pursue free drug. Just to walk you through the scenario, when there was open patient assistance programs, we would have figured out, in this instance with patient KT, they did not have commercial insurance. They had a Medicare Part D plan, which is a governmental plan. And in that instance, we did have to verify their household income in order to see if they would qualify for the free drug program. And then we also needed to make sure that the patient's insurance had already approved brand name Valsite. So we had quite a hefty feat. We had a couple things we needed to do. We needed to get the patient's verification of household income, which is usually a copy of their last year's taxes. We had to work with the provider to pursue the brand name Valsite. And oftentimes this process is counterintuitive and it can be frustrating because we're having to work with our mid-level providers to pursue a prior authorization in hopes that the patient will potentially qualify. And sometimes you have to go through an appeal process, depending on the type of insurance. You might have to go through an appeal process to try to get the brand name approved. And there are oftentimes when the brand name product Valsite is not approved, but you have to go all the way through the process and get that second denial before the drug company will approve you potentially for assistance. And so I just wanted to provide some additional resources. I don't have all the solutions, but just a few things that we do. On the slide, there are these grants that do open up. We are very blessed to have a team, a PAP team. We have a specific PAP specialist that does focus on our admitted as well as our non-admitted solid organ transplant patients. And so that individual routinely monitors the HealthWell Foundation, the website, to see when different grants will open up. So I wanted to share this link with you all. It does have pretty much all of the the repeat offenders, those expensive transplant medications that our patients are on. You can go and see if the grants are open, and you can hover across the status. It will tell you if it was closed. It'll give you information, I believe, on the date. And so typically at the beginning of the year is usually, I believe, when the HealthWell grants will open up. And that's the best time that you can kind of flood the applications, try to get your patients in there, get them approved for patient assistance. So as we start to get to the end of the year, sometimes we'll speak with our social work colleagues to say, okay, this patient needs to be on valganciclovir for 6 months. Let's see if we can help them limp along, help maybe social workers willing to approve coverage for the medication. And then maybe we can get them approved for a grant, for the remainder of therapy. Or depending on what medication we're talking about, maybe we can do an alternative. Maybe we can look at our transplant test claims and do a switch. And so oftentimes these are the strategies that we will use is either a grant. We'll look for, is there a switch that we can do? Is there social work assistance? Or is there additional assurance that we can encourage the patient to apply for? In my mind, usually that is our KDP programs or our kidney disease programs. That's usually the routes that we would go. And so with that, that was the information that I had for you all today. I believe we are going to move into a question and answer session. And I think there's some comments in the chat.
Yes, thank you so much, Dr. Keith and Dr. Isaacs. We do have some questions for you both that have popped up throughout your sessions. To start off with Dr. Isaacs, from an insurance perspective, the Libre 2 and Dexcom G6 may be the options that we have in a lot of cases. Are there considerations between these two, such as is one easier for patients with lower health literacy? And how would you sort of make the decision between those two?
Yeah, that's a great question. And I think we are seeing that Dexcom G7 and Libre 3 also are really, the insurance coverage has been good, but still it's the question kind of how do you decide between Dexcom or Libre? There are definitely some key differences. The wear time, the 14 days versus 10 days. And while a longer wear time is nice because you don't have to change it as often, some people, things just don't like to stick to their skin. And if it falls off too early, that's going to be an added expense. You can always try calling the companies to get replacements, and they will, but only you can't call them like every week. So that's a consideration. With the Dexcom systems, there are those additional codes. And especially with the G6, there is a transmitter code and there is a sensor code. And I have found people with very low health literacy sometimes trying to explain how that transmitter is good for 90 days and the sensor is 10 days. And it has taken people a very long time to fully grasp that. And then when it is time to change that transmitter, it has led to some confusion that I've needed to kind of step in. I think with the G7, that has gotten a lot easier, but there still is that 4-digit code. So that still is a little bit of an extra step. And then I think another key differentiator is that the Dexcom systems do have some additional alerts. So Libre is kind of designed to be a little simpler. There's a high alert, there's a low alert. That system actually does update every minute. So you do get the alerts pretty quickly, but there are not predictive alerts. There's not a rise rate, there's not a fall rate. And so if someone wanted kind of these additional alerts, that would lean me towards going to a Dexcom. Also, at this current moment, if someone wanted to integrate directly with the pump or CG or connected pen, or even a lot of mobile apps have more compatibility with the Dexcom CGM versus the Libre, that might be another differentiator. But overall, I will say we're now seeing a lot more similarities than differences between the two systems.
That sounds great, especially I'm sure insurance does drive a fair amount of these decisions. So knowing that they're similar is overall is pretty helpful. Great. And for Dr. Keith, I'm finding that copay cards for expensive drugs such as brand name Myfortic or Prograf have annual limits. Have you run into this and what happens at that point?
That is a great question. So we definitely look at that. It depends. Sometimes the annual limits are enough that we're able to get through the majority of the year, and that's a better situation rather than to keep them on the generic medication, generic version, or to switch to something else. But we usually do the math. So, for example, I believe Prograf was one of the medications written in the comment, and Prograf, from memory, I think has like a 3,000 annual limit. So for that one, for a lot of our patients, it is able to cover the cost of the medication, but it just all depends on how expensive is the copay to the patient. Of course, if you have a $500 copay from Prograf, then your 3,000 annual limit isn't going to get you throughout the year. So it really just depends. In that case, there have been patients where we've started with one medication and then we've switched to something else, but of course, for something like Prograf, we definitely want a long-term plan. We really don't want to do a ton of switching back and forth all the time. So that's an excellent question. Yeah, we have to get creative sometimes and bridge the gap through social work or the patient themselves sometimes.
Great. Thank you so much. And another question for Dr. Isaacs, what is the expected lag time and variation between glucose on BMP, capillary, BGFS, and interstitial fluid taken with CGM? Some patients have been concerned that those readings were not close.
So I'm glad this question was asked, because this is a really important area to cover. They are not going to be exact because interstitial fluid is inherently different than the capillary space from blood glucose monitoring or finger sticks, as well as different from like the venous space when you're getting a BMP. So some differences totally expected. And generally what we say is that up to 20% variance in kind of a fasting steady state. And it might seem like a lot, but there's just variation. And the thing is, especially when it comes to finger sticks, those are not perfect. I've had multiple patients say to me, oh gosh, I don't trust this thing because my finger sticks are different. One time I was like, where I always ask people, I'm like, what kind of test strips are you using? Can I see them? And like this one time, someone hands them to me and they're expired from like 2 years ago, right? So the accuracy sometimes of the finger sticks as well as the technique can impact that. But the thing is, there is this lag time when you eat something and glucose is rising. It's going to rise faster in the venous and capillary space as compared to the interstitial fluid space. And so we do expect a greater rise. Similarly, if someone recently gave insulin, there would be a greater difference. The way we describe this to patients is through what's called like the train or the roller coaster analogy. Like if you're going up a steep hill on a roller coaster, the top of the roller coaster is going to be higher than that back of the roller coaster, but they're all getting to the same space. So CGM is a lot more about looking at the trends and patterns versus getting caught up in what that exact value is. So generally 20% on a steady basis, but if it's rising or falling, it can be more, and that is okay.
Wonderful. Thank you so much. I think it kind of speaks to the point that what we're comfortable with isn't always the most accurate, and it can be hard to change that practice too, going from the finger sticks over to CGM. And one last question for Dr. Keith. I find a lot of our patients, physicians, and nurse coordinators struggle with understanding how insurances work, especially the coverage gap. Do you have any easy to understand resources that you use to help increase understanding outside of the information on the Medicare website?
Yeah, I really wish, this is a very great point. A lot of people struggle with insurance, you know, from our pharmacy learners to the nurses, the social workers, inpatient pharmacists, inpatient providers. And really what I have found is, so we've done, so this presentation that I'm giving, I've given an alternate version of this, you know, to our colleagues. And I think that that's been helpful. Also too, honestly, just continual communication with the team. I wish I had a resource to pull all together that really would help people to understand. Every patient's insurance situation is different. Even when you have a Medicare Part B plan and a Medicare Part D plan, the setup is always very unique to how the patient has it set up, whether it's primary, whether it's secondary, whether or not they have an Advantage plan and there's a coverage gap, and then the copays are going to vary. So between the varying insurance coverage types and the changing rules of the patient assistance programs, it really requires a pharmacist that is well integrated in that inpatient side, but also on the outpatient side to keep abreast of the insurance changes. And fortunately, like for my role, and I know it's very unique, not everybody is you know, maybe has a position like this at their transplant center, but I can see all of the insurance claims, and so I'm kind of like that intermediary to speak with the patient, speak with the provider, and tell them specifically what is needed. But of course, as the providers continue to rotate day to day, you do have to re-educate and re-ask and explain, this is why I need you to pursue this prior authorization. But it is very confusing. I've worked with a lot of the same providers for the last 7 to 8 years, and it's just continual education. So I wish I had a better answer for this question of, like, you know, to really help increase understanding, because it's constantly changing and it's going to be specific to the patient. So even if a patient has KDP, and to be honest with you, even when we understand the insurance coverages, I've also seen with some of our outside pharmacies that maybe are not as familiar with how the insurance is supposed to be billed. Sometimes things are billed incorrectly, and that also can lead to confusion. So one of the first questions you should also ask is, after, like, what insurance are you billing, is to really ask if there's any additional insurance, and like which insurance should be billed first and for which medication. Because oftentimes pharmacies will default, let's say, for example, to a Part D plan or a commercially insurance plan, and maybe they don't know that the patient has Medicare Part B, and that might solve part of your problem right there. But it's going to be very specific to the patient, and I know that this may or may not help the confusing part, but it's very complex. So you're really going to need somebody on the inside.
Thank you so much. I think you just identified some really helpful resources and points to go forward and help educate our teams at our own centers. We do have a scheduled break. Thank you so much for Dr. Isaacs and Dr. Keith. Your expertise is much appreciated. We hope you enjoy the rest of the day. We'll give everyone a chance to get up and run to the bathroom, grab a coffee. I know this is a long session, longer than usual. So if you could meet back around 11:10, 10:10, or 8:10, depending on what time zone you're in across the country, we would really appreciate it. Thank you both so much again.
Great. Thanks so much for having us.
Thank you. Thank you. Have a great day.